programs in your department implement for your residents?
Thank you, Doctor. Thank you for the attendance. Thank you for inviting me today for this valuable conference. Thank you for the head of the department, Dr. Tamer Gouili, and the organizing committee, Dr. Rania, Dr. Tania. I prepare a brief and comprehensive talk about this issue. Substance use disorders are a major public health concern. Nurses play a crucial role in prevention, early intervention, and the treatment of substance use disorders. Proper education equips nurses to identify, assess, and manage substance use disorders. Integration of substance use disorder education ensures better patient outcomes and reduce stigma. في عندنا طبعا gaps كبيرة جدا أو limitations barriers طبعا بتعمل limitation of the focus on addiction courses in nursing program. We have only one topic or lecture. If you are please. About the barriers and the gaps, it's very important here that we will focus about the nursing addiction courses in our programs. In our bachelor program, there is one topic for the 7th level students, in for bachelor program students, and it is very, very lacking in our courses. We also we all try to ask for integration of more courses or more topics from the beginning levels. From the beginning levels, from level 2 or level 4 or the primary levels of the nursing students. Also, we have a master program, a master degree in nursing addiction for 3 years. General course and 2 specialty courses, and it is very comprehensive for its preparation for our master students. But we noticed that there is a lack in the registration for this master course. Also, we have diploma course, and this is diploma course 2 years academic diploma. But we also focus that we have we lack registration in this diploma. So this diploma is free. So my suggestion now is to integrate or to make a transform for this diploma to be a professional diploma. To be professional diploma, to be more applicable, and to make hands-on experiences. We have lack in clinical exposure to substance use disorders treatment settings. We also have insufficient training. This is the gaps and the barriers that limit us in the addiction courses training education in our programs. Integration across all subjects, embedding the substance use content across all courses ensure relevance and hands-on experiences, and will embed our students and make our students more competent in dealing with substance use disorders. Students gain a broader conceptual understanding of substance use disorders. Holistic learning prepares them to work in diverse clinical settings, and this is very important. Integrative teaching models have shown greater impact on retention and application. Strong pharmacology foundation are essential for safe practice. Some nurses lack sufficient drug knowledge upon graduation. Understanding types of substance and their treatment is critical. Proper knowledge improves safety, patient education, and outcomes. In conclusion, a comprehensive education on substance use prepares healthcare professionals better, reduces stigma, and improves patient care. Equip graduates to meet the growing challenge of substance use disorders in healthcare settings. A call to action in get substance abuse finds into all levels of healthcare education. And thank you.
What do you think, Dr. Abona, residents, they don't apply for the diploma in your department?
First of all, doctor, we have no residency program, we have internship program. So I think that our graduates fear of stigma. I think this is the most issue, the most important issue. Some of them are working in addiction settings or private hospitals, but they are very few numbers of people.
Professor Mona, I thank you for this remark. Sometimes the medical professionals working with substance use patients do have timidity or difficulty to announce to others that we are working with substance use patients. They see it as a stigma. And I think that this is also should be included in the curriculum. That why? I mean, the first time any medical discipline sees our patient, it's not us, it's not the psychiatry. The first medical professional who sees the substance use patient is the ER, the emergency teams, with the nurses, and the emergency teams in convulsion space, in delirium, in overdoses, in accidents, in car accidents, in orthopedics. These are the patients all over the world who see, who first one see our substance use patients. So we should not be stigmatized about our profession. Thank you so much.
Thank you, doctor.
Professor Ahmed. Professor Ahmed Said, again, he's a professor of vascular surgery. Professor Ahmed, I think you have many things to tell about the link between us and addiction unit.
Thank you, Dr. Alia, for giving me this opportunity. I'm really happy to attend this session. And yes, we have many things to do together. We need each other much more than the current situation. We need a lot of information from you, and we need that you know more about the possible complication of the care that we are providing for the patient. I'm sure the majority of you know why are we dealing with vascular surgeon. We see that they ruin their veins while they inject, and first it starts with the superficial veins. After a while, they start to use the deep veins, resulting in a more advanced procedure, more advanced disease, the DVT. But till that moment, we do not have devastating problems. The problems really start when they start to use their arteries to inject. Here we have two problems. The first one is that injecting a substance in the artery may be very injurious to the endothelium, leading to spasm, and spasm leads at the end to thrombosis and severe ischemia, which is not amenable to any vascular repair, and even not very responsive to the medications. And the other complication, which ends usually by limb loss, is the development of an infected femoral aneurysm at the site of injection, because they inject under completely septic condition, not aseptic. So the development of an infected aneurysm means for us in vascular surgery a ligation of the artery. You cannot do revascularizations in a septic field. So this is the magnitude of the problem. And till that moment, many of you know this information. I'm supposed to tell you more about the numbers, the incidence, the magnitude of the problem, which substance is more injurious than other substances. But I will disappoint you by telling you that we do not have enough information. We string the patients we have for so many reasons. I'm sure you know about it, but the more disappointing issue is that these patients have major challenges in their care. They do not get the best care ever, even like other vascular patients. And I will tell you why. The first thing is the stigma. The patient doesn't want to tell his family, please take me to the doctor because I have a problem in my groin. Why do you have this problem? Because it's due to injection, and they do not know actually that he's injecting something. The stigma is from us. It's more from a young ER physician, especially newly graduated vascular residents, when he meets such patients and he feels that this is something shameful, so he is not very willing to help him. He starts by telling him about the obstacles and the complications that he's going to face, which are all true. He is not lying. But the way you tell the patient and start to get from him an informed consent differs greatly from a young physician, from someone experienced who really understands that this is a disease, not a stigma. So, as a result, many of these patients leave hospital, refuse treatment initially, go to another hospital, repeat the cycle, and they say hear the same thing again, the third hospital, fourth hospital, and this has a burden on the healthcare in general, but specifically the patient arrives at the end with a very bad stage of the disease where he's really much worse than at the first presentation. And again, this worsening of his outcome even more than what we are telling about. So this stigma is affecting his treatment and really needs correction. The other thing that makes him get worse medical care is the nature of the health system in Egypt. We all know that either you are paying cash for your treatment, or you are under the cover of health insurance, or you are have private health insurance, or you are treated by the Ministry of Health, what we call قرار علاج على نفقة الدولة. To the best of my knowledge, we don't have coding and reimbursement that is clear for such patients. When I want to write a report, I don't know how to write it and how would they approve it. And if he is on health insurance related to his job, he definitely doesn't want to have a report telling his job that he needs this care and that and that. He asks us, please don't mention that I know I need something. If it's a medication, okay, but if it's something where I have to make a surgery or put a device, please don't let anyone know that I need such device. On the other hand, if he's a cash-paying patient, the modalities of treatment available for some patients, especially with those with femoral pseudoaneurysms or any pseudoaneurysms, are sometimes very expensive. The cheap solution is always to ligate and wait. If it survives, then he's lucky. If his foot does not survive, then he is for amputation. And this happens to so many people. And the medical service, as you all know, is getting very, very expensive in all fields. So when it comes to a patient who is not covered by insurance or by and most probably he is depleted financially because of his problem regarding substance use. So we have so very limited solution for such patient. And this again means more delay of his management and worse outcome for the problem that is already has a bad outcome. The third challenge we have is that, let's say, he sought medical advice early and he is admitted and we start the treatment. We made the procedure that is necessary to salvage him. But now we have a patient who was on substance and he stopped it and he may develop withdrawal symptoms. And here we have very, very little information how to deal with the patients. Not only that, the majority of the hospitals where we work lack the presence of a professional psychiatrist who can really deal with such problems. Or at least they can ask an expert to come for a visit and give just a broad plan, and we will leave. There is nothing called that. There is a in-house for such patients. So they don't get the best care at the hospital. We try to solve our problems by giving them more morphia, more opioids, just to keep the pain until they get discharged and continue in a specialized centers. But this would be a lengthy procedure, lengthy time. So we need a lot of information from you regarding this issue, because it's really difficult for us to deal with the patients during this critical period of their medical care.
And what about the need for training program in your undergraduate or postgraduate curriculum?
I don't believe we need a real training regarding how to treat these patients in particular. We do train the vascular resident for such procedures, any aneurysm, any intra-arterial injection, whether this was inadvertent or intended. They know how to treat patients with thrombosis, but when it comes to this patient, it's not really a vascular training. They need to have better communication skills, not only for patients with substance use. Actually, we have this problem even in any problematic patient. They don't really know how to handle the angry patient. They don't know how to deal with the patient with multiple comorbidities, who has been seeking medical advice in every specialty, and then coming to them, they don't deal with him well. So we actually need better communication skills, not specifically related to the substance use.
Thank you, Dr. Ahmed, very much for that. Please, I want to add something.
Thank you for letting me for this addition. I want to focus about the National Strategic Plan for Addiction in Egypt, which is aligned with WHO, made 30 goals. The most important goals in conclusion: number 1, to reduce the prevalence of substance use disorders by 30% by 2030. Improve access to quality treatment and rehabilitation. Integrate mental health and addiction services in primary health care. This is the most important we need to. And for promotion, we have to promote, we have to prevent before the occurrence of substance use disorders. And combat stigma and discrimination, like all focus on this issue. Enhance monitoring, data collection and research, which we take also in this field. So this is the most important issues I want to focus in conclusion for this talk. And thank you very much.
Now we have Professor Samuel Dako from Nigeria, teaching psychology, and we need to know about your addiction curriculum in university.
Thank you very much. Just very briefly, I'm going to just share with you the role of psychologists, especially when it comes to addiction management from where I come from in Nigeria. First of all, just to give you a background of what it means to be a psychologist in Nigeria. Yes, unlike other parts of the world, the field of mental health is still growing in my country. So for a member to have a license to practice in Nigeria, he must have a first degree and a master's purely in psychology, so that he can be able to get membership and license to practice as a psychologist. Now, unfortunately, we have about now the third university working on addiction certification programs where psychologists can be able to actually get such trainings. Where it's important for us to know that much of the trainings that psychologists have been getting for now is inculcated in their curriculum as part of the trainings they are having, especially those that are clinical psychology, not any other branch of psychology for now. So a lot of them have actually undergone training at Colombo, UTC, UPC, and I have the license to be able to practice in Nigeria and in other parts of the world. One of the challenges we have as psychologists practicing addiction science in Nigeria is that a lot of people claim they are psychologists, but you do not understand the relationship between psychology and addiction. Relationship with personality related to adjustment, assessment and all. So many counselors feel they are psychologists. The second problem we have is religious leaders. A lot of religious leaders, imams, pastors, they claim they can do the work of psychology, which is a problem. If they understand that what psychologists do is beyond counseling, is beyond talk therapy, then they will be able to focus more on training of psychologists as it is. Why? The challenge for you and for me is this. We need to know, and we are aware that addiction is a brain disease, yes. But the problems related to addiction is far beyond just one problem. There are multiple problems which psychologists have the skills and the competence to help to take care of related issues that are surrounded and around addiction. Without psychologists, just medical treatment will be insufficient and be difficult to manage. Therefore, in Nigeria, we are working, because I happen to be the member of the Nigerian Psychological Association. At one point, I was the Assistant National Secretary. So at the national level, we are working to ensure that psychologists have more courses in addition, so that as they are trained, they can actually specialize in addiction management than it is. And much more making efforts towards getting license and certification in universal treatment curriculum program. Thank you very much.
In the last 10 minutes of our panel, in brief, Professor Noha, if you would like something from our addiction unit in Cairo University, what do you think the pharmacology department needs from us? In a very brief message.
Training.
Clinical practice for them for how many days or how many you think they will attain the skill and the attitude they need when they encounter the substance use.
Thank you for mentioning the attitude. Like everybody mentioned, we might not want to stigmatize whether the patient or the process.
I think training, and this will require at least for them to spend a month to be able to grasp the minimum clinical knowledge.
Thank you. Professor Nermeen, for you, the young neurologist specialist, freshly graduate, what does you need from the addiction psychiatry unit to upgrade or to get ready your neurologist, newly-fledged specialist?
Two things. The first one is establish a very practical short-term module to study the basics.
Yes.
Second, to create a channel for multidisciplinary team discussing case by case coming to me.
Thank you so much. A collaborative way of guidelines inside the ER. This is an excellent idea. Excellent idea for the practice, Professor Don. Professor Nermeen, an already present, huge collaboration is already present within the toxicology department. But regarding the occupational department and the addiction psychiatry unit, yes, from your own, the brief message you can send for the back.
Actually, even the collaboration at the level of the toxicology department, I want it to be enforced, to be systemized, such that toxicology ER is the first line, is the front line for managing the patients with overdoses and with those patients, but those patients will come more times, and some patients we see them recurrent patients. So I think collaboration is crucial. I think our step is the first step, but you are the final, the most important step for the prevention and for promotion of this issue, as Dr. Mona said. Regarding the occupational medicine department, I think also it's very important in our curriculum, in our training, especially for the clinical toxicology, the part for the addiction, and rehabilitation is very important in enhancing the skills of our residents and our doctors.
Mr. Mona, in a brief message, you already enriched our vision with the SDGs or the goals of the WHO and the needs for collaboration. In a brief message, what can be urgently done to get ready for the freshly specialist in nursing addiction, and nursing psychiatry?
First, thank you very much, Dr. Dania. We want to collaborate with your unit. You have a diploma. We are having a diploma also. We have to make this diplomas realistic. We have to collaborate this, and we have to share our visions, okay, our objectives, our outcomes, to implement our diploma for our graduates. I am convinced with you about we have to make our graduates more professional in this field. So I am dreaming to have an intermediate diploma or intermediate professional diploma with your department and your unit. Okay, and I want to implement this as soon possible. We are in need for this for patients, for our graduates, for our community as a whole. Thank you very much.
Professor Ahmed.
I'm not going to ask for a whole module or training course or diploma. I will ask just for a comprehensive lecture, making our residents more in touch with the substances. You will be astonished how they do not know anything, so you can call it substance use for dummies, because they know nothing. We need a roadmap how to deal with such patient until he gets the real service. So in the first few days, what to do until he gets in good hands to deal with this problem.
Sometimes we may do detoxification inside the vascular surgery unit. We have many cases, we are never ready to refer the patient to our detoxification unit. We need to make the detoxification measures in the neurology department, yes, in the toxicology department, and in the vascular surgery. Lots of orthopedic incidents, by the way, because they are coming from an accident. They started the withdrawal from heroin. They started the withdrawal from stimulants. Yet he has a leg broken. He has a stroke. He has something that he can never be moved. So we need to make our detoxification inside the other specialty.
By the way, we have a major problem understanding the substances, because the new substances that you were mentioning, and I really like the term polysubstance, because we have been facing this without giving it a name. So we are old-fashioned. We know heroin, cocaine, opioids, cannabis, but we don't really know the new substance. Yes. So when someone says this word, it's like putting a stone in front of us, and what should we do with it?
Go ahead, Professor.
I think this will be my future dream for all the medical specialties, and we started this as a small unit in MSA University, and I'm really annoyed that as faculty of pharmacy and medicine and nursing and physical therapy and dentistry in Cairo University, the mother university, we do not have the interprofessional education hub, which is very important. We started this with just physical therapy, pharmacy, and dentistry students. Yes, here we have all the disciplines of medicine. and I think we should engage the different medical field professionals as students, how to talk to each other and understand the different points of view. This will implement in the students as they grow and as they go into their profession, how to deal with the physician. I'm talking from my perspective as a pharmacist, how to deal with the physician, how to deal with the nursing department, how to deal with the dentistry. If some, of course, most of the addicts, they do have dental problems, so they need to be implementing this. So hopefully this will be our collaborative work for the coming, we should have a 5-year plan to collaborate doing this for the benefit of the next generation. Thank you very much.
Finally, Dr. Samwi. Finally, Dr. Samwi, for your university, Joe's University, what do you think that the other medical specialties in your university needs from you, your psychology department, addiction knowledge?
Okay, thank you very much. Like we have actually identified other disciplines, there is need for us to understand the role of each other. No specialty, no area of knowledge is actually enough to deal with substance use alone. There is need for us to be able to collaborate. So in my university, there is a need for all of us to be able to put hands together. I give an example of the issue of eyes. We discussed the issue of eyes in my country and how, the street name for it, you have eyes cream, eyes burner, and all of that. And a lot of doctors said they've never heard about it. And it's okay not to know about it. But when professionals who understand it, we need to learn from each other. And because psychologists have a knowledge to go into the street, to do expert observation, get the street information, we have a role to play. And it is high time that all of us put heads together as professionals, medical doctors, psychiatrists, psychologists, social workers, so we can be able to help people to get over the issue of drugs and drug addiction. Thank you.
Thank you. Audience, do you need any questions from the panel? Do you have any rising comments or questions for our guests in the panel?
My question is to Dr. Ahmed. What about the effect of smoking on vascular system?
The effect of smoking, the effect of smoking is well known and well established many years ago. The endothelium gets injured by the nicotine, and the tar damages everything. So we have smoking as a major risk factor for development of atherosclerosis and hence peripheral arterial disease, as well as the aneurysmal disease. It's a major problem for us that we do not cessate smoking after treatment. We always tell them at our clinics, you have to do this and that because in order to be better in the coming time, you need to stop smoking. But we really know that it's not that easy. And I remember at the time that there was like a hotline for stopping smoking, but I'm not sure it's still working at the moment. Maybe we need more support from you for that, because we really have worse outcomes when the patient is continuing smoking. And bear in mind that smoking in a country like Egypt is getting higher than the so-called first world, like the Western world. So they have better outcomes because they are getting rid of smoking, while we are having more smoking, especially in females and children.
Thank you.
Thank you very much.
Regarding the vape, to the best of my knowledge, it has the only advantage of lack of tar, but the nicotine is there with a higher concentrations. So the effect on the endothelium is the same. It's not protective at all against arterial disease. Maybe it's different for lung disease because tar is the main problem, but for peripheral arterial disease, nicotine is there and in a higher concentration than the regular cigarette.
Another question here?
question to Dr. Vascular Surgery. As regard the eye drops injection with heroin, what are the complications with eye drops, as it is anticholinergic action has more hazardous related to endothelium artery vessels more than heroin. Commonly, eye drops such as methyl, medrapid, using for dilatation of eye, making very severe vasculitis, even endocarditis. Yani, what is the differences? Why eye drops more hazardous than heroin injection view? Thank you.
I'm sorry to disappoint you that we really don't have comparisons between the different substances. And I have real difficulty to understand the substance you just told me, because the patient is not going to tell me in a medical way, I am using this substance. He just gives me a name and I don't know what's in it. So I'm always expecting the worst without knowing which substance led to the worst outcome. We understand that the majority of these medications cause irritation to the endothelium, leading to endothelial edema, and this leads to thrombosis. How much thrombosis? To the level of the fingers only, or to the whole hand, or to the forearm? I don't have actually data, and this was my disappointment at the start of my speech, because we do not document this, and nobody is happy to say, yes, I'm part of the study dealing with the substance, this substance, and I'm ready to give you my long-term outcome to really know if this was good or bad.
More rapid action of that thing. So you expect the worst case?
I don't know. I cannot expect if this is good or bad, because maybe it's vasodilating. It leads to opening of more vessels and avoids the severe ischemia. But I don't have actually a real prevalence or description of the problem.
The rate of death in our studies from mixing heroin with this cyclopentolate, death rates because of the mixing cyclopentolate with heroin are much more higher than injecting heroin alone.
Then probably
These are the data in our side.
this probably explains why I don't know this, because probably such patients die before I interview with them, or they are in a very bad condition to the extent that I cannot admit them to surgery. So probably I'm ignorant about it because the severity of the substance.
Last question.
Hello, my name is Marco Magdi. I'm American Psychological Association campus representative for Division 17 on Positive Psychology at Ain Shams University. It's very obvious that clinical psychologists and psychiatrists are doing the good job for treating addiction. But let's have some insights about positive psychiatry and positive psychology. How we can build resilience for the human, so that when he is facing some challenges, his resilience to not moving to the addict itself. So positive psychiatry and positive psychology focusing on physical health, focusing on nutrition, on sleep, on having positive thinking, and getting rid of cognitive distortions. Yes, and this positive program that we can do will reduce the amount and reduce the probability of having addicts, and this we can do a prevention. So what do you think about this?
We're totally, from the addiction psychiatry point of view, we're totally with you that positive psychiatry will add to the prevention. So if Professor Mona, Professor Noha curriculums, Professor Nermi curriculums, all curriculums can add to the prevention by adding certain positive psychiatry, positive psychology elements inside the young practitioner, inside the young physician, going into, I mean that you need to raise the assertion skills inside the adolescent. So whenever he sees the drug, he can say no. I'm sorry, it's not my way. I'm sorry, I need to go to my gym. I'm sorry, I have to go to pray. No, I don't use this. No, I prefer going to movies. No, don't talk about with me about these subjects again. So this attitude of positive or positive assertion skills, I guess the curriculums in nursing and occupational therapy, because many people are using inside their working places. So the substance use in the working places relating to occupational curriculums is very high. I mean, the drivers are using, the technicians, صبي النجار, الميكانيكية, these are working places. So the occupational curriculums, if we can add the positive psychology knowledge into these curriculums, I guess the prevention factor you are looking for would be very important.
This will reduce the cost of. This will reduce
See,
the
Dr.
cost
Dan-
of.
So Dalia, I can add something. I totally agree with you, but we have to consider also the social context, the peer pressure, especially in this adolescence stage, and also the genetic factors. It's very, very important. Thank you.
Thank you, dear professors from different departments.
استنى عشان في جروب فوتو.
Thank you very much.
ألف شكر، اتفضلوا للجروب فوتو مع